Thank you so much for that wonderful introduction. I work in the Department of Health, but my job is not to deliver healthcare. My job is to help build a system that lets all of you deliver healthcare. And I know the Secretary of State feels the same way about his role. What brought me to the job? Well, I'm a software engineer by training, but I know and love the NHS. 10 years ago, I designed and delivered a digital service to help junior doctors find their feet when they arrived in a new clinical environment. My user research showed that it was taking junior doctors months to find out who their colleagues were, which training sessions they had to attend, where the HR department was, and so on. This is because they were working flat out treating patients and didn't have time to worry about the administrative staff. It's a sight familiar to anyone who works with the NHS, that our clinicians want to spend as much time as possible helping patients. Our job in this room is to help liberate that expertise and compassion so it can be deployed where it's needed most. If you've heard me speak before, you may have heard me talk about the two cultures of tech and healthcare. Tech is all about failing fast, iteration, collecting the evidence as you go on. Health is all about getting it right the first time, proceeding on the basis of caution, making sure your approach is grounded in years of clinical research. Tech is agile. Healthcare is careful. But I think that binary is less true when it comes to urgent and emergency medicine. In situations where you have no patient history and every second counts, then you can't afford not to be agile. That may be why digital transformation is relatively advanced in urgent and emergency care. And today, you'll hear about some great examples of the work that's going on in that space. But I want to take a step back and talk about the big picture. What are we doing at a national level? Where does NHS fit in? And how does that impact local NHS organizations on the ground? So let's start with strategy. Last autumn, we published the Secretary of State's Tech Vision for Health and Care. The purpose of the vision can be summed up in one sentence. We want the NHS tech to be more like the technical architecture of the internet, open and interoperable, capable of constant incremental improvement, and able and willing to adopt innovation. This vision is our roadmap of how to get there. Like a delicious banoffee pie, it consists of 3 layers. It starts with infrastructure, which is the biscuit base. This comes first because we can't have great digital services if we can't get the basic infrastructure right. This means developing and enforcing common standards. Standards on privacy, encryption, interoperability, and above all, on data. Too much of our data infrastructure is of such poor quality as to be unusable. I'm not even talking about health records. Something as basic and useful to an app developer as a canonical register of local NHS services is often unavailable. And it's not just standards on technical architecture, but standards on governance, procurement practices, and contracts. We need to move away from a world of monolithic, whole stack procurement to a world of modular contracts where we can swap and upgrade services as they get faster, cheaper, and better. As I've said many times, it should be as easy for a CCG to switch GPIT providers as it is for a small business to switch bank accounts. But we are not interested in micromanaging every interaction between suppliers and NHS customers. We know from past experience that we could easily become a bottleneck to innovation. That's no good. So we will set a minimum level of standards consistent with ensuring system-wide quality and interoperability. And within that context, we will let local NHS teams buy whatever they want from whoever they want. We don't care who builds the plug, as long as it's safe and it fits the socket. And as you've heard from Terrence, our guiding principle throughout is one of openness. Open, so anyone writing code from the NHS knows what's expected of them. Open, so insurgent innovators can take on giant incumbent vendors. The next layer of our Banoffee pie is digital services, the banana and the toffee. This is partly about doing a few things once for the whole country, whether it's the NHS.uk website, NHS login, or the digital public health campaigns. It's partly about empowering CCGs, trusts, and surgeries to get on with commissioning or building great new services for patients and clinicians alike. And it's partly about ensuring the NHS gets a chance to benefit from the best health tech out there. What all our services must have in common, the service standard, is a commitment to user needs. The people who use our services, whether patients or clinicians, should not have to see or worry about the tech. Tech should be useful but invisible, sitting behind the service, facilitating a great user experience. Patients don't care whether 111 or eConsult is delivering the access. They just want the NHS urgent or emergency service. The third and final layer of our tech vision is the innovation, the cream on top. Because if we get the infrastructure and the digital service layers right, we can build or slot in the latest innovations. AI is a good example of this. There's huge excitement around the potential of machine learning in healthcare, some of it even justified. But an algorithm cannot do a lot with a crate full of handwritten notes. It's no coincidence that the early advances we've seen in health AI have tended to rely on imaging data, where there is less potential for variation and human error. Until we fix the data layer, so it's possible to access NHS data from wherever you are in the NHS, just like you can access your email from any device, we will not be able to deliver innovation at scale. So we need to get there. That's the strategy. What's the delivery? That brings me neatly onto NHSX. As I hope you've heard by now, the X stands for user experience. We're setting up NHSX because our tech leadership has been too dispersed. There were so many bodies, agencies, and teams with a say on tech policy that managing the decision-making apparatus has become kind of an end in and of itself. It took us 7 months to get sign-off on the principle that email and not letters should be the default way the NHS communicates with patients. And that's a case where all parts of the system were in agreement. So NHSX is bringing together our tech leadership into one decision-making point. This will radically simplify the complexity that's blocked tech transformation in the past. It will mean we can get things done. But it is not just about fixing the organigram. The other reason we're setting up NHSX is to bring the culture, the openness, the productivity, and the constant iteration of the internet to the way we deliver tech in health and care. What does that mean in practice? Well, first, it means spreading innovation much faster. We often talk about a health tech ecosystem, but too much of that ecosystem is stuck in the Precambrian. Promising prototypes get stuck in endless pilots. Great ideas make a huge difference in one hospital, but they don't spread. Health tech suppliers who've been approved by one hospital trust should not have to waste time replicating their evidence base for a different trust just up the road. We are clear. New technology should not take as long to teach the NHS as a new drug does. So a big part of our early work will be on understanding the barriers to the adoption of new technology, as well as the creative process itself. Second, NHSX will be the body that mandates and enforces our standards. You might have noticed that's something of a theme for today. Our message to suppliers is, if you choose not to follow our standards on privacy, security, interoperability, and so on, you will not be selling to the NHS. And we will not be releasing the money to commissioners. This will be a big shift for some parts of the NHS. It will not happen overnight. But we've learned from our experience elsewhere in government that tying standards to purse strings is the only way to ensure systemic change. The flip side of getting tough on standards is that we will agree those standards in collaboration with all of our users, from clinicians to carers, patients to technologists, suppliers to civil society groups. Everyone in this room is passionately interested in the power of technology and the potential of data. That's why we're here. But the reason we care is that we care about people and their needs. And we cannot stress this often enough. I look at projects like the SCRA mobile pilot that NHS Digital are delivering for the London ambulance service. It means paramedics can access a summary care record on an iPad without the need for a smart card, saving a sick patient having to repeat themselves. I see projects like the Tech Integrated Health Management Project in Surrey, using a package of wearables and internet-linked devices. NHS clinicians are providing monitoring and support for dementia patients in their own homes in real time. For the patient, it means fewer hugely stressful trips to the ED. For the carer, it's being able to dash out to the shops for a pint of milk, knowing that your device will alert you and a professional if something goes wrong. It's the feeling that you are not alone. That the NHS really is there for you at every moment that counts. When a busy nurse has been on his feet for 12 hours and patients are piling up, there's no excuse for asking him to enter the same data twice because the systems aren't compatible. This is who we're in it for. I'm looking forward to working with all of you to make it happen. Thank you.